I'm going to present this paper, which I found interesting from my point of view, which is whether or not you should do a platelet transfusion before putting in a CBC in patients with thrombocytopenia. So this is a paper published by a group in the Netherlands back in May 2023, and it's done in Amsterdam mainly, looking at two sites across two specialty, hematology and ICU. And the question was, does giving prophylactic platelet transfusion reduces the risk of catheter-related bleeding in patients in hematology and ICU when the platelet count is between 10 to 50, I think, which is a problem that we see quite often on our unit as well. And so the background is, as we said, it's very common to have thrombocytopenia and patients requiring CBC infusion. There are guidelines out there, but there are varying guidelines, and there's no clear evidence as to what the cutoff is, and no consensus as to when we should transfuse and when we shouldn't transfuse for patients needing CBC placement. So the British Society of Hematology suggests anything less than 20. American Society for Oncology said anything less than 40 to 50. AGBI doesn't really specify what the threshold is for specifically for CBC insertion, but it just says that anything less than 50 for patients needing major surgery or invasive procedures to consider transfuse platelets before doing that. So why are we concerned about that? Because because of all the potential complications with thrombocytopenia, but also on the other hand, platelet transfusion is not without its own risks. So you have all the risks that comes with giving blood products, and also it's quite a scarce commodity, so you don't really want to be using it unless it's absolutely necessary. So how do they do it? So it's a randomized open label non-inferiority trial, and it's set at a margin of a 2.5 increase in the absolute risk of grade 2 to 4 bleeding. And the documentation of the bleeding is at the point of insertion, 1 hour post-insertion, and 24 hours post-CBC insertion. So it's about one-to-one randomization to the transfusion group versus the no transfusion group, and it's stratified according to the trial center and the catheter type. So they included also all sorts of catheter, not just central and the standard CBC. They also include large bore like VAS cath and include tunnel or non-tunnel catheter. So it's pretty obvious where you can't really do a double-blind trial with this study. So it's unblinded for the patient, but wherever possible, they try to blind it to the operator, so they don't know which group they're assigned to in terms of what they're looking at. In terms of the consent, ideally, an informed consent is taken before the randomization, and that isn't a problem with the hematology patient because it's almost like a expedited elective procedure for them. But for ICU, it is a bit difficult. So they presume consent until the patient or next of kin is able to give consent retrospectively. And if patients do not consent in the ICU group where they just assume consent initially, then they'll withdraw the patient from the study. So based on the calculation, they need a sample size of 196 CBC insertions in each group to get a power of 80% with an alpha level of 0.05, and assuming that there is no loss to follow-up during the study. And this is just a standardized how you grade the bleeding. So it's graded as 0 with no bleeding, grade 1 where there's any oozing, any hematoma that will stop with manual compression of less than 20 minutes. Grade 2 is anything more than 20 minutes or needed minor intervention. Grade 3 is if you need any radiological or any surgical intervention or any red cell transfusion without causing any hemodynamic instability. Grade 4 is patient with hemodynamic instability or actually death as a result of the complication, which is usually fatal hemorrhage. So as said, this is 10 done in Netherlands across 7 academic centers and 3 general hospitals, and the study was conducted between February 2016 to March 2022. And the inclusion criteria is patient must have a platelet count between 10 to 50 within 24 hours of the catheter insertion. And the exclusion criteria is anyone on any therapeutic anticoagulation, any congenital acquired bleeding defect, or initially INR greater than 1.5, but in the midst of the study, there was new evidence saying that the bleeding risk at 1.5 is, or higher INR is actually quite low, so they increase the threshold to INR greater than 3 for the exclusion criteria. So patient can be enrolled multiple times within the study as long as the interval between each CBC insertion is greater than 24 hours. So anything less than that, they won't be able to enroll again. So then this is, as we said, so 411, which they randomized into 2 groups, and then after some of the exclusion, they get about 373, which is about 1-to-1 in the transfusion, no transfusion group. So that gives us about, I think it still works out to about 193 to get the statistical value out of this study. And this is just a table to show that the randomization works out about similar characteristics in each of the group. The baseline is about the same in each group. So I'm not going to go through each of that. It's pretty clear that it's about the same. So as we said, the intervention was to give 1 unit of platelet transfusion before the CBC insertion versus the control group, which is no transfusion. In terms of how they do the CBC, it has to be ultrasound guided. It has to be done by an experienced operator, at least someone who has done 50 CBC insertions in the past. And ideally, the catheter should be inserted an hour post randomization, and it should be done according to the local guidelines. So there's no specification as to exactly how you insert the catheter. And as we said, the primary outcome is looking at any grade 2 to 4, the incidence of grade 2 to 4 catheter-related bleeding. I'm just going to magnify this a little bit. But essentially, it shows that there is 4.8% in a transfusion group had grade 2 to 4 bleeding, whereas as compared to no transfusion group is 11.9. So there is about 7.1% increase in the absolute risk of getting grade 2 to 4 related bleeding with CBC insertion, and that works out to be about 2.5 of a relative risk increase. In terms of the secondary outcome, which is either looking at grade 3 to 4, like other grades of bleeding, hematoma formation, the size of the hematoma, whether or not they need any red cell transfusion, and whether that increases the length of their ICU stay or hospital stay in general for hematology patients, or any transfusion-related complications. There are all the incidences are all higher in the no transfusion group. However, they are not statistically significant as compared to the grade 2 to 4 bleeding, which was the primary outcome. So what have they concluded from the study? So I think they said that there is a higher incidence of catheter-related bleeding in the no transfusion group as compared to the transfusion group, and therefore it did not meet the predefined margin for non-inferiority, which was a 2.5 increase in the incidence of bleeding as compared when you compare the transfusion versus the no transfusion group. However, interestingly, what they suggest from the study is that it depends on where where you want to do the CBC and which cohort of patients you're doing it in, because if you want to do it in a hematology patient, they suggest transfusing if they're thrombocytopenic. However, for the same platelet count, they suggested no transfusion strategy in the ICU patient. And the rationale for that is that the etiology of thrombocytopenia is slightly different in these two groups, where the ICU patient is more of a consumptive thrombocytopenia, whereas in the hematology patients, it's more of a hyperproliferative thrombocytopenia. And there's also we need to take into consideration the platelet function as well, not just the platelet count on its own. So with hematology patient, there may be an issue with the platelet function as well that is not as significant as it is seen in ITU patients. So, and also it's a setting of where the patients are going to be after this procedure. So because the patients on ICU are more intensively monitored, you pick up the problem a lot quicker and you're able to intervene a lot quicker as compared to patients on a hematology ward. So that's what they concluded from the study. And also, as you can see, interestingly, a lot of the bleeding complications actually happened in the hematology ward, where it was can't quite remember how much is the number. 18 out of the whole 22 bleeding complications occurred in the hematology patients rather than in the ICU group of the patients. So what are the strengths and the weaknesses of this particular study? So the strength is this is a multi-center randomized controlled trial. The protocol and the way they're going to analyze the data is well established before they publish the paper. They also included an intention to treat analysis to minimize the risk of bias. And they've included a wide range of CBC, which is reflective of the population where they did the study. They also did a cost analysis in this study, and there is a low rate of protocol violation when the study was conducted. So it was done according to how the protocol was written. But on the other hand, it's a single country study. So can we extrapolate it to other countries? Do we have the same population? Is it comparable? It's very difficult to say. And also the way it's being practiced may have slightly different practice between countries. So that may add a level of complexity to that to the situation. Is there a Hawthorne effect? Because the operator is aware of the trial, you can't really blind it. So have they changed their behavioral pattern because they know that they're involved in this study? Do they change the technique, whether consciously or subconsciously? And also there's the issue of patient heterogeneity. They give everyone 1 unit of platelets regardless of what the starting platelet count was. And they also didn't measure the platelet count post-transfusion before they do a CBC. So you don't really know one platelet increase, you don't really know how much it increased it by and whether it's a sustainable level of platelet count before they do the CBC insertion. So is that another reason why you get a difference in terms of the bleeding rates in the two groups that they looked into? And also, as I briefly touched on, is the bleeding risk the same in the ICU patient as compared to the hematology patient, because the etiology is slightly different? But it does seem that the bleeding risk is higher in the hematology group. And then, is this a confounding factor? We don't know, because most of the bleeding happened in 2 centers. So is there any reason? Is there any operator issues or any patient issues or any local protocol issues that may have contributed to the higher bleeding episodes in these 2 centers? And there is missing data. So 7% of the population did not have a primary data available. So this may introduce an element of bias when they come to analyze the data. So what is my conclusion? To transfuse or not to transfuse? I think it really depends on when you're doing it, how urgent it is, what type of catheter you're going to put in, and where you're actually going to put it in. And is it a compressible site, a non-compressible site? Am I going to put a vas cath in versus a standard CVC? But I think if I have the time, the luxury of time, I probably would choose to transfuse on the side of caution before I do any CVC insertion. But that's my take on it. And that's the end of my presentation. Thank you very much. Any questions?
Again. Sima, can I be nosy and ask you to go back to the forest plot to look at the rate of bleeds?
Yeah.
I'm just interested.
This one?
Yes. Am I right in saying that the non-tunneled lines seem to have a higher rate of bleeding than tunneled?
It seems like that, but then actually when you read in the discussion bit, it suggests the other way around, which makes more sense, but I'm not sure whether it's because in the actual text bit, it does say the tunnel has a higher rate of complication, but it's the opposite in the forest plot.
Okay. I don't know what to make of that. Thank you.
But I think I would also like to know, like, whether there's any difference between a large bore catheter and a standard lumen catheter, if there's any difference in the bleeding rate.
I haven't put that here. They've only got tunneled and non-tunneled, but not like vas cath versus.
Yeah. It's not here, and I tried looking in the supplement appendix. I couldn't find it either.
Any other thoughts around them? Hands up for transfuse. No one in the room.
Well, it seems like 40,000 to 50,000, the rate is 2, and that goes 5-fold when it is 10 to 19,000. So it makes me think the closer you are to 10,000 watt, the better it is to transfuse.
So by the time you go less than 20,
Yeah,
you're less likely to bleed.
just going shifting towards
Yeah.
bleeds. If you're not, it's probably. But who's doing these in the rheumatology?
This is in the Netherlands, aren't they?
It's just.
Also, interestingly, the cost saving bit doesn't really, it's not true. You don't save cost. In fact, it's more expensive to in the no transfusion group, because what they find is that eventually they need a transfusion anyway. It's just a bit longer than the first 24 hours, but eventually they all get platelet transfusion after this.
That's a good point. They'll get it transfused because someone else comes along and says the platelet's low.
Yeah, it's just the upfront cost is more expensive in the transfusion group because they take that into account, the platelet, 1 unit of platelets. But like post 24 hours, the no transfusion group patients went on to have platelet transfusion. So the cost wise is a non-issue.
Any other questions from LRI? Any questions? I was going to ask that, but then I didn't want to torture Sima by asking more questions. Does anyone in the room, and either rooms, involved in the T4P trial? How does that differ? Excuse me. I mean, the answer is no one's involved in the T4P trial.
Trial?
That's a New Zealand trial.
What trial was it, Joe?
P4P, that's recruiting now, and it's related to platelet transfusion before lines. So it can just be like, what's it doing through exclusion criteria?
Above 18, platelet count less than 50, plan to undergo a low bleeding risk invasive procedure, and platelet transfusion
In central lines.
So it's kind of similar.
So we shall know more when the T4P multi-centre UK trial comes out and subclavian lines don't get done on the haematology ward. More relevant to our own population. There you go. I've run out of silly questions to ask now. Well, I'm trying to delay talking about DKO. Thank you, Sivan.
All right, thank you.
So hi, anyone who hasn't met me, my name's Jo. I can see a new colleague at the back who I've not met. My name's Jo. I'm one of the SC7 dual anaesthetic and ITU trainees. And I have been tasked, well, I chose to talk about, out of all the topics I was given, I chose to talk about hyperglycemia and hyperglycemic emergencies. There are two main conditions that come to mind, and I'm going to skirt around the topic and broaden the scope a little bit. So, plan of the presentation, I have some cases. Everyone is going to have to do some thinking, please. We're going to go through some definitions because that's what we need to do. And importantly, there's a continuum between the different conditions that I'm going to talk about. I'm going to spend some time talking about pathophysiology for the benefit of anyone who is still sitting exams, has exams coming up. But if you're not interested, then switch off on that bit. And then when I come on to talking about the management, which is basically reading off the diabetes group guidelines, then you can switch back on again, because that bit is the important bit. I am going to include some evidence-based medicine where the guidelines are applied for our senior colleagues who may already know the pathophysiology and management, but want to know where the guidelines are coming from. Some intensive care quirks, which I will dwell on as long or as little as the room wants me to dwell on. There's one slide of controversies. And so that I don't clutter my slides with millimoles per litre, every time I mention glucose and ketones, the unit is millimoles per litre. I just want to declutter the slides because my slides tend to be quite cluttered with things. All in a day's work. Today is hyperglycemia day. Anyone who has a QR code scanner, please scan the QR code. It will bring you to a written down version of the 4 cases that I'm going to talk about. And I'm going to put a few minutes on the timer, and I just want people to have a think about the cases, write down any thoughts. They're all anonymous. And then we're going to go through the cases at the end. And hopefully, if my presentation works, you'll feel a little bit better about the cases at the end compared to at the beginning. That is the aim. So if you look at the cases and you go, ooh, then that's fine. Hopefully, we'll clear it up by the end, especially when I tell you the answers. So, case number 1 would be a typical patient for Glenfield, left over here, a 60-year-old gentleman who goes to have a stent for a STEMI, previously fit and well apart from smoking, whatever. Comes to the unit and the nurse comes to you and says, the glucose is 20, they've been very proactive, they check the ketones is 0.2, and the patient is otherwise all right. So, are we bothered about a glucose of 20? Does it matter? Do you want to do anything else? What do you think the diagnosis is, if there is one? And why do we do what we do in this patient? Case number 2 is a typical rhesus patient, less so seen in Glenfield, more so seen here. 20-year-old, fit and well, abdo pain and vomiting, sleepy, tachypnic, glucose of 20, ketones of 7. Pertinent gas figures are there. Do you want any other numbers to help your diagnoses? What are you going to do? And then a very enthusiastic A&E colleague says, the GCS is 7, we must intubate the patient. Are you going to intubate the patient? What is going to aid your decision? Case number 3, medical ward. 74-year-old with a background of poorly controlled diabetes is coming with a cough. It's a bit sleepy. BM's 40. Again, a very keen nurse. Has checked the ketones and Case number 4, Glenfield patient, 60-year-old, Glenfield anaesthetics patient, 60-year-old who's listed for a toe amputation. You go and see a patient on the ward. Glucose is 4. Someone's been keen and done a pH of 7.1 with a normal lactate. So why are they acidotic? What else are you going to look for? What are you going to do about it? You're going to enthusiastically go and take this patient's toe off. For anyone who hasn't had the QR code already, please scan the QR code. I'm going to put so that my voice gets a rest. Another 3 minutes on the clock to force you all to think about it. Right, so these are the 4 conditions that we're going to talk about, which may or may not correspond to the 4 cases that we talked about. Number 1 is hyperglycemia and critical illness. Number 2 is the one that immediately comes to our mind, which is DKA. We'll talk about euglycemic ketoacidosis because even though it's not a hyperglycemia, it's a spectrum of a similar illness. And then hyperosmolar hyperglycemic state, which to me, is still this nebulous condition that exists, and you know it's really, really bad, and the patients who get it are frail, so we could do with a little bit more guidance about what to do about them. So number one, hyperglycemia and critical illness. There's some very long and complicated words there, but I'm sure you'll notice that when patients come in ill, they have a stress response, words that are there, cortisol, catecholamines, and it pushes their glucose up. They also get insulin resistance, and then we give them glucose as well. We make their noradrenaline glucose, NAC goes in glucose, amiodarone goes in glucose, and then their glucose goes up. Does it matter? It does, because lots of studies going back decades have shown that patients who have hyperglycemia have a higher mortality. They have a higher healthcare associated infection, so they get HAPs and MAPs. And then at the bottom, what it says is that they also get critical illness acquired weakness. And we know that these are the patients who don't get off the trackie, don't get off the vent, stay here for ages. And hyperglycemia has been shown to be a really strong correlating factor. So the natural thought process is, if hyperglycemia is bad, shall we bring it down? So this answers the question in the first case: do we need to bring this glucose down? If a high glucose is so bad in conditions, particularly MI, traumatic brain injury, cardiac arrest, they are associated with bad outcomes. Two landmark studies that anyone who does the exam will have to read and will have to regurgitate. Number one, this Belgian bloke, in his own single hospital, randomized his patients to either have really, really tight glucose control between 4 and 6 or 10 and 12. And then he somehow demonstrated that the ones who had really, really tight blood glucose control seemed to have a lower mortality. In the surgical patients, not necessarily the medical patients. And then lots of places around the world have tried to replicate this, but they can't. NICE-SUGAR 2009 is the biggest study that has tried this, multi-center randomized control trial, similar sort of target ranges. And actually they flipped the opposite side, and they showed that the groups that were randomized to the tight control trial actually had a higher mortality rate further down the line. And they had lots of hypos. And not only that, they never actually managed to get that low. So the average glucose in the tight control group was actually 6.5. So they can't even get that low because the nurses were panicking, turning into and off, rightly so. So therefore, SCCM, this American Critical Care Society, have come up with guidelines that say, you know what, just aim for 7 to 10. And actually it's more important to avoid hypos. And that's the generic advice for hyperglycemia on ITU. So, and then there's other conditions like traumatic brain injury, post-cardiac arrest that have their own guidelines, and usually they will just say avoid hyperglycemia. They will never say aim for 6. And even in the SCCM guidelines, it will say aim for 7 to 10, and then below we read about the strength of the evidence. It's literally like 5 paragraphs saying we really have no evidence for this target. Like, we can't prove that this is good for you, we can't prove it's bad for you, but don't for it. Aim for 7 to 10. So that's what we do. A note on sliding scales: this is for anyone who might have spent a lot of time working on the medical wards or surgical wards and come here and see our sliding scales. We have our own sliding scales. I'm sure you'll see it in the back of our drug charts, which is crossed off with a scale, and you can re-prescribe it and it will work for most patients. There's the BAS protocol, which is in the middle section of the page, which is this ridiculously complicated flow chart. I don't know if you guys have looked at it. And it's supposed to be a more intensive protocol to really bring the glucose down, and I very, very rarely seen it used. On the wards, we will be taught again and again that you have to give a substrate, because remember, hypos are bad for you, definitely bad for you. So on the ward, you will have to run dextrose or dexaline. On here, actually, most of our patients are on feed, so they don't need dex. And in some circumstances, and from my experience, please correct me if I'm wrong, this tends to be the acute, immediate admissions, post-MI, post-laparotomy, when their glucose is 24. Then we just start them on a what we call dry sliding scale, which is basically just insulin. And because the nurses are monitoring the blood glucose so closely, it is safe to do that without glucose running in the background. That's all I wanted to say about sliding scales. Any questions about hyperglycemia but not an emergency? Moving on to the actual main topic, hyperglycemic emergencies. So the two, DKA and hyperosmolar hyperglycemic state. I said that my slides were busy. There are some complicated words which define it, which anyone sitting exams will need to be able to regurgitate this while sounding smart. Diabetic ketoacidosis is characterized by hyperglycemia and ketoacidosis due to an insulin deficiency and catabolic response, not in that tone of voice. Whereas in contrast, hyperosmolar hyperglycemic state, less of the ketosis, and we'll talk about why, but the hallmark or the thing that really makes what makes you think HSS is this person is really dehydrated, and because their glucose is so high, they actually have to take, I call it sticky blood, hyperosmolar blood, and that comes with all its own problems, which we will talk about. These are two hyperglycemic emergencies. On the spectrum are the other ketoacidoses, just for context. So that's euglycemic ketoacidosis. And I feel like we've seen this more and more now because of the drugs that we use. Definition is ketosis, but without hyperglycemia. And there are multiple causes of this, which may or may not be related to diabetes. So causes, the number one textbook cause to look out for is the SGLT2 inhibitors, which I still cannot say, dapagliflozin, empagliflozin, those ones. If your patient is on one of them and they are acidotic, please check the ketones, because the way these drugs work, I don't know if anyone is familiar with them, they are apparently, according to the heart doctors and the diabetic doctors, wonderful drugs because they force the kidney to pee out glucose. So you give really good glucose control to patients, and because they're peeing out, they're automatically diuresing. So for the diabetic heart failure patient, they are great. For someone who's sick and they keep peeing out their glucose, then that's when they become sick. That's when they become ketotic, and then it becomes our problem. Starvation, alcohol, those conditions are associated with glycogen deficiency in the liver, and therefore the next physiological response is to go ketotic. And if you get so ketotic you're acidotic, that's when you're ketoacidosis. Sepsis, liver disease, adrenal insufficiency, and pregnancy, these are case reports, which we could talk about if anyone is interested. But certainly anyone who has liver disease or pregnant and they're diabetic, and they're not hyperglycemic but acidotic, again, just check the ketones. But I feel like we're getting really good at just checking the ketones anyway. Just randomly. So that's the spectrum. Diagnosis, any guidelines, any textbook, any paper that you will read will give you a longer version of this table, and I've sort of distilled it down a bit. What are the diagnosis criteria for DKA? What are the criteria for HSS? And more relevant to us on ITU, when do we get a phone call from research or a medic saying, the pH is 6.9, this is severe DKA, please can you review? The guidelines say that you have to come and review. So these are the criteria. Severe DKA is ketones more than 6. I feel like I see this all the time, but obviously I don't see the unselected ones. Bicarb less than 5, pH less than 7. Potassium is sort of way by. So these are the ones that we will get called for on ITU. HSS, particularly we call it severe HSS, which when their blood is sticky enough, so their plasma osmolality is more than 350, and they're acidotic with it as well, which could be a host of reasons, which we'll come on to. Then they are classed as severe HSS, and again, the guidelines will say, please get HDU critical care. Plasma osmolality can be calculated or measured. For the purpose of looking after someone who's HSS and their hyperosmolality is coming from sodium and glucose, it's not projected very well. This formula will do what you need to do, because for these patients, the high bit is sodium, maybe sodium, definitely glucose, almost definitely urea. Note that if you're looking after someone with ethylene glycol toxicity or any of those weird osmols, you need to do calculated and you need to do measured, but that's a whole different. For your HFS patients, if they've not been drinking antifreeze, this formula will allow you to look after them properly. Pathophysiology. If anyone doesn't want to engage brain, then switch off now. Switch back on when I talk about management. So how does DKA come about? I've spent years trying to learn this, and I'm still not sure I can say it without this flow diagram. The primary event is insulin deficiency, which is what we know, especially type 1 diabetes, they have an absolute insulin deficiency. So your cells cannot, particularly your muscle and your liver cells, cannot take up oxygen, cannot take up glucose. So those cells think that they're starving. And if those cells think that they're starving, they will send out a stress response, catecholamines, cortisol. And what those hormones do is tell your body to go into fight or flight mode, which means make more glucose
from other sources. So gluconeogenesis, the glycogenolysis, all of those words which you just set up in an exam, just spit them all out. So the result is that you get even more glucose, which your cells still can't take up, and now you're breaking down proteins and you're breaking down fatty acids. Particularly when you're breaking down fatty acids, they give your ketones, and ketones are acidotic, which is bad. So we've got hyperglycemia in a vicious cycle. We've got ketosis, which gives you acidosis. I keep saying it's bad. That's another debate. But anyway, you get a ketosis. And because you're so hyperglycemic and your kidneys can't reabsorb it all, you then get an osmotic diuresis, which is why your patients are so dry. And because now their kidneys are just unregulated, peeing out glucose, you also get a gross electrolyte disturbance because your kidneys are just like chucking out whatever comes. This is a diagram that is taken from a book which says the same thing. I will share the slides if anyone prefers these type of flowcharts to tables. Random MCQ facts. Anyone still got exams coming up? There are 3 types of ketones. 3-beta hydroxybutyrate is the one that is measured. Whatever number you get on your ketone measure is not real. The real number is higher because there are 2 other ketones. The end. Well, there you go. And we passed our MCQs. Don't need to do it anymore. Exactly. But for anyone that does, you heard it here. So that's how DKA comes about. And because it is a spectrum, how does that compare to HSS, hyperglycemic hyperosmosis? So do you be HHS and not HSS? That's what I'm saying.
But I'm HSS.
Easy mistake. So textbook says that it tends to be type 2 diabetic people that get HHS. Therefore, the degree of insulin deficiency is less. There's still a little bit of insulin kicking around the body. Crucially, there is enough insulin and enough reaction to insulin to suppress ketosis. Ketosis is suppressed in HSS because they're HHS because there is enough insulin. However, the cycle of hungry cells make more glucose is more marked, so there's more hyperglycemia. And because the blood is stickier, more hyperosmolar, there are more complications of your sticky blood, which is what? Lots of fluid shifts. If you've got a hyperosmolar extracellular space, the natural thing to do for your semi-permeable cell membranes is for your cells to chuck out water, particularly your lungs, particularly your brain, because they're the ones that are susceptible to things. So that's one thing. Your cells are dry. Then, like in DKA, your kidneys just chuck out anything that's coming, including glucose, including all the ions, so sodium, potassium, phosphate, they all get peed out. So regardless of what your measured serum sodium, potassium, phosphate is, know that you are overall deficit. Their stores are probably depleted as well. And because the brain is particularly susceptible to fluid shifts, you will get drowsy patients, you will get patients that look like they're weak on one side because they've got a dry, wrinkly brain. So they have global or focal neurological deficits, which is what I put on the slide. So this is the DKA slide again, and how does the pathophysiology of HSS compare? So I've grayed out the bits that are less prominent in HSS. More stress response, more hyperglycemia, more hyperosmolarity, more osmotic diuresis, more problems with electrolyte imbalance. You can talk about that all you like, but as we know, it's a continuum. I finished talking about pathophysiology. Anyone that's fallen asleep, wake up again, please. Management of anything. This is for anyone who has an OSCE or a Viva to sit. How do you manage an emergency? These are the 5 steps. Call for help. Follow. Oh yeah, assess and necessitate. That's for the OSCEs. Follow the trust policy. The reason these slides are in is because I first made this presentation when I was an ST3, and I updated it. This is why all of this stuff is still here. So, management of DKA. There are 4 priorities. If any of you talk to me about DKA, which some of you have done, there are 4 priorities that the inpatient group highlight, and then they detail over a 40-page document. QR code there for anyone that's interested. Number 1 is treat the precipitating cause, even though that's sort of, we do that for everyone. Restore the circulated volume because we know they're dry. Correct the electrolyte imbalances, and the particular one to look out for is potassium because you're about to chuck a load of insulin at them, and suppress the ketogenesis because that's what's going to help with the insulin. 4 things.
treat the cause, give them fluids, check the potassium, give them insulin. 4 things. And the rest is just filler. Here comes the filler. Number 1, fluids. If they are hypotensive, then give them a bolus. If they're still hypotensive, give them more bolus. Lots and lots of fluids. Particularly DKA patients tend to be young and they will. The guidelines will tell you to give normal saline, and they will tell you to adjust the potassium that you add to that normal saline. That's the overall picture. If anyone is interested in the specifics, this is what it says. But I'm not going to read that because that's in the guidelines. Lots of fluids, and don't let your potassium drop. That's the overall gist. Insulin for DKA, because you need to suppress the ketones, you need to give them insulin regardless of what their blood glucose is. And the starting rate is 0.1 units per kilo per hour. And if they are known diabetic, continue any basal insulins. And then, like I said, your aim is to suppress the ketone generation. So even when their blood glucose is low, give them glucose, continue the insulin. Updated guidelines in 2022 said consider reducing your insulin rate. So do that if you like I said, if you're going to give someone a lot of insulin, their potassium is going to start going from their extracellular to their intracellular compartment. And we don't like hypokalemia because that's when people arrest. So monitor and replace, and obviously monitor your glucose and ketones as well, because that tells you your response to treatment. The guidelines give you some targets. They're quite nice. And they give you a backup plan. If you're not achieving these targets, then you can increase the insulin. So be empowered to do so. The guidelines. And then I'd like to also say that when the ketones are less than 0.3, when the pH is resolved, that is resolution of DKA, and that should happen in 24, 48 hours-ish, is what the guidelines say. Less urgent things, find the precipitating cause, look for your infections. And then there's some guidance about this. You've got time to read the guidelines, fix and stuff. If they're not eating and drinking, put them on a sliding scale, as we've talked about before. If they are eating and drinking, call the diabetic nurse and they will put them on a nice subcut regime, which may or may not. And then we've been taught this in F1. Don't stop the insulin infusion until you've given time for your subcut injections to work. ITU quirks. I've got one slide of this, which are even for discussion or for people to have a rant. Lots of ITU people that have been around for long enough, even if they don't believe it at the beginning of their ITU career, will believe it at the end that normal saline is the devil because of hyperglycaemic acidosis. So when you have DKA patients on here, you will find that sometimes, depending on who's on, instead of having their normal saline with potassium, they'll get plasmolite and Hartmann's, and then either central KCl or they will get force-fed Sandoz. And there are some small trials that says that actually if you use this approach, the acidosis resolves quicker, but the outcomes are the same, is what the trials say. So do what you wish. But if in doubt, then stick with the guidelines because they're safe, they work, and we can deal with the chloride to 150. Number 2, when do we intubate someone with DKA? Now, I saw that someone on the note said, this is DKA, do not intubate. So what words influence? Maybe I've written down as well. So when does someone with DKA need intubate? Who was I on overnight? I was with Kingsley and Falarin. I think it was Falarin that went down to see the DKA chat. And I asked Falarin 2 questions, which informed me whether I wanted to go down and see the patient straight away or whether I could say. So one question was, what is the level of consciousness? And the second question is, what was the PCO2, preferably on an ABG? My thought process, again, and we share, is that obviously if they are decompensated to the fact that where they're not protecting their airway, then they need intubation. If they are not compensating for their acidosis by respiration, then they also need intubating. Now, there is something called the Boston rule, which I am happy to talk about if anyone wants me to. But the general gist is, for any level of acidosis, there is a accepted level of PCO2, which tells you that this person is actually okay. So that dude downstairs, even though his PCO2 was, his PCO2 was 3 on a BBG, and that's probably as good as it will get, like maximum powered lungs. What am I trying to say? The Boston rule will tell you if your ventilation is efficient enough, is the most efficient thing at that time to overcome the metabolic acidosis. And it's when the CO2 starts coming up that you think, right, this patient is about to decompensate. Now they need intubation so that we can take over the ventilation. The Boston rule is a formula that tells you, supposedly, but realistically, maybe I shouldn't, a vibe of a venous PCO2 of 3 is probably okay. If someone has DKA and you tell me that their PCO2 on an ABG is 4, I'm going to be scuttling along and saying, are you coping? Does that make sense? So look at the level of consciousness, look at their PCO2. Be geeky and talk about the Boston rule. Number 3, bicarb. Has anyone seen or used bicarb in DKA? How sick were they? Very sick. So I haven't even bothered to try and use formal language, just in desperation. And really, mainly the reason is if they're so acidotic, they can't generate blood pressure, or you're about to intubate them and you know you're about to make the acidosis worse because they're going to be apneic for 30 seconds, and you just want something to stop them from arresting. So those are the 3 really sort of ITU quirks in managing DKA, which the guidelines acknowledge that these issues exist. I actually wrote this before I read the guideline. And then I was like, oh, the guidelines thought about it too. Anyone that will still have involvement in children, DKA in children, the problem of electrolyte imbalances is much more serious in children because they cannot handle sodium load, and any fluid shifts put them at much higher risk of cerebral edema. So overall, the vibe, if you read the DKA protocol in children, overall the vibe is give less fluids, don't like conservatively give fluids, titrate, don't just throw the fluids in. Start the insulin later after you fluid resuscitated them. And also, if your child then has decreased consciousness, assume that they have cerebral edema, and the treatment of cerebral edema, because you've given them so much fluids, they're now diluted. And the treatment of choice is hypertonic saline or mannitol. I'm not going to spend too much time on this because this is allowable on TV. And I put this in when I was SC3 and I needed to do it. Happy to move on. I think this is one slide on euglycemic ketoacidosis, because the treatment is mostly similar to DKA. Some quirks. A simple starvation ketoacidosis should get better just by glucose. If you give them insulin, you put them at risk of refeeding because of the electrolytes flying all over the place, and B, they're not actually insulin deficient. You think you have starvation ketosis and there is no diabetes in the background, try just something. Number 2, alcohol, similar pathology to starvation, but they are often thiamine deficient, which means that if you then give them glucose, they can't put the pyruvate into the TCA cycle, and you will divert them to a lactic acidosis instead. So if you have a suspected alcoholic, give them Pabrinex first, then give them glucose. They may or may not need it. If your patient has a euglycemic ketoacidosis because of SGLT2 inhibitors, treat them exactly the same as DKA. They are likely to be very sick. They just get very acidotic. The only difference is that you start the glucose much earlier, obviously, because they are not hypoglycemic. For our anaesthetic colleagues, a side note, the peri-op management of S2 inhibitors changed in the last couple of years. So if they have elective surgery, stop them the day before and on the day of surgery. The books are lying when they say don't admit it. Check daily ketones while they're in hospital. And if anyone on SGLT2 inhibitors, this goes for all of our colleagues, they come in and you check their drug history and they're on one of these SGLT2 inhibitors, withhold it while they're acutely unwell. And then check daily ketones. Any questions about that? Management of HSS. Why do I keep writing HSS? That's so embarrassing. I checked it. So even the guidelines for this are very fluffy, because the population of people who get HS tend to be the older, frailer, more comorbid, and it's much harder to blanket say, give a litre of fluid and then give another litre of fluid in 2 hours, because the next thing you know, your lady with heart failure will then bubble and then you've got another problem to deal with. But the overall 4 principles are the same. Treat the underlying cause, give them fluids, electrolytes, and instead of suppress ketosis, the number 4 is controlled restoration of plasma-like osmolality. Remember, I said that the major problem with HSS is electrolyte and fluid shifts. So the idea is to do everything nice and slowly in a controlled way. The guidelines say, if you can, and everything is caveated by if you can, because of these older, frailer patients at risk of pulmonary edema, give a litre of normal saline, just give it. And in the first 6 hours, trying to get 2 or 3 litres in. These are the British guidelines that I've worked off. Lots of American papers that you read, and even my trusty ITU textbook, talk about fluid deficit and 10 to 22 litres. And I decided that that was too complicated because I don't know how to work out fluid deficit. I actually really like these UK guidelines, which just say give a litre in the first hour, aim to get 3 litres in the first 6 hours. And obviously, if you've got a patient that's the size of me, maybe stop at 2 litres. If you've got someone who's got heart failure, stop at 2 litres. It's just a little bit simpler than if you try to read an American paper about this. So the contention is whether to give, there's a lot of contention in the paper. I've never actually heard this conversation in my life, whether to give 0.9% saline or to give 0.45%. The guidelines say give 0.9% sodium chloride, even though your patient is hypertonic, because your 0.9% sodium chloride is still relatively hypotonic to that. So actually, if you flood them, as soon as they come through the doors with 0.45, you're going to bring everything down too quickly. So the 0.45 is reserved for when they are nice and puffy, but they're still hyperosmolar.
After the 3 litres, you consider 0.5%.
Not necessarily, just keep, so later on there's a slide, so you monitor the plasma osmolality. And if it's still coming down, then just carry on with the 0.9%. The 0.45 is a backup one. I don't know if they've dropped out again. Let's keep going that noise. I'll keep talking until someone calls me and say I can't hear you. So the question, thank you. Question of insulin. So remember, the problem isn't absolute insulin deficiency. The problem is dehydration. So you only give insulin if there are indicators of insulin deficiency, i.e. there is a ketosis. And even then, if there is a mild ketosis, they recommend half-rate insulin. And if they are really quite acidotic, severe HHS, then you give them the same insulin dose as DKA. But if I remember correctly, you give it after the initial fluid hydration, because really you're trying to hydrate them before you bring the stickiness of the blood down. Monitor, so this comes to what you were asking, Tony. How do you titrate? How do you decide when you go from 0.9 to 0.45% sodium chloride? You monitor the plasma osmolality, you just need to keep calculating it. But monitor the sodium and potassium, monitor the glucose, because these are likely to swing up and down. There are some targets. No more, no less than a glucose of coming down at 5 millimoles per hour. And when you hit sort of 10 to 15, then don't overdo it, because you don't want to render the patient hypoosmolar. This last one comes up in the books. Expect the measured sodium to go up when your glucose comes down. Does that make that intuitive sense to everyone, or if we're giving naughties? So those are the, I'll talk through it. If anyone is bored, then have a 45-second rest, because this doesn't really matter. But I'm going to say it anyway, in case anyone is interested. Or for anyone who's sitting exams and needs to study hyperglycemia. So, like I said, when you have HSS, you are peeing out your sodium. Your body is overall depleted in sodium. However, when you measure your sodium, it is going to look more. And the reason is because there's so much glucose in your blood, then actually your measured lab sodium is incorrect, unless if they specifically correct for your glucose. Do you remember that table of hyponatremia? There's like the pseudo-hyponatremia. These patients are actually pseudo-hyponatremia. So ironically, when you give them fluids and you bring their glucose down, their measured sodium will actually come up, which isn't a problem. They're not actually getting stickier because their glucose is coming down. Does that make sense? That was easier to explain than I thought it was, as long as it makes sense to them. No one's stopping me. Complications. As I've said again and again, the problem in HHS is fluid shifts and electrolytes. So there's two sides of it. Number one, depending on how quickly your patient developed HS, they are suddenly hit with a hyperosmolar insult. So that's what I said, where you've got sticky blood, the fluid inside your cells rush out across the cell membranes, you get a dry brain, you get dry lungs. Particularly your pons is susceptible, and that's when you get central pontine myelinolysis. It's rare that you get direct central pontine myelinolysis from HS, but there are cases. More commonly, and the one that we have some control over, is to make sure that we don't overdo it the other end and crash their osmolality down too much. And I've actually seen 2 cases of this. If you don't monitor their osmolality and their urea comes crashing down, their glucose, their sodium, everything comes down, what you end up with then is that the fluid, your plasma, is now hypoosmolar compared to your dry and wrinkly lung and brain cells. So the fluid rushes back in. You get pulmonary edema, which we can ventilate, that's not a problem. But if you get cerebral edema, that's irreversible, so that's bad. And also, if your blood is leaving your blood vessels to rush into your brain, you also get a low blood pressure, despite you being on fluids. So that's also bad. So measure the plasma osmolality, try and hit the sweet spot in between. This is the other stuff that you say in the exam. Give them dotaparin, check for pressure ulcers, keep them warm, look for the underlying cause. Back to our cases. This is a different form. Please scan it. If you can be bothered to write your thoughts down, then write your thoughts down. Otherwise, there's a question at the end to say, do you feel more confident? Please say yes, because then it makes me feel good. Only if you genuinely do. Case 1. Actually, don't write. Can someone shout out the answers at me? Case 1. What's that?
Joe.
Yes, hello. Yes?
Joe, I have a question. How quickly or slowly do we reduce the plasma osmolality?
At 3 to 8 milliosmoles per hour.
Oh yeah, it was also fine.
Thank you.
Thank you. So case 1, I heard someone say stress response. Yes. Does it matter?
Yes.
Yes. What to do about it? Sorry? Observe? What are you going to do when it keeps going on? What are you going to do if the next one's 24?
Nice.
Sorry? Yeah, it's manuscript. That was easy. Case 2. What's the diagnosis? Yay. What other information do you want? Bicarb, yay. What are you going to do? There are 4 things. Fluid, treat the cause, insulin. Yay! Are you going to intubate? PCO2 on an ABG? Nah, or watch it. Assuming, of course, that you're not choking or anything like that. Yeah, that's stuff. If anyone really wants to talk about the hospital, we can do some shared learning after the presentation. Shared learning. Case number 3. What's the diagnosis?
HS.
Any other information? What else do you need to know? Yes. I think so. I don't know what you're doing. Osmolality, yes, that's the one. I knew I'd do it. What are you going to do? 4 things. Treat cause. Fluid. Electrolytes. Maybe insulin. What's the one that I kept going on about? I think that we're going to be careful. Monitor the osmolality. Insulin or not?
Depending.
Depending. Are they ketotic? Are they acidotic? Maybe later. Case number 4. Diagnosis. Or what else do you need to know to make the diagnosis? Sorry? What? You thought he was starved? Oh, yeah. So he could be starved. So you've got to check the ketones. What else are you going to do? Is it just starvation ketosis, or is there something else? tablets.
Medications.
Yeah, looking for a fiance. What are you going to do?
Designing
Stop what? Sorry?
the medication.
Stop it. Yeah, and then what are you going to do? Assuming that the ketones are 6. Sorry?
Get some sugar.
Do some sugar and
Insulin.
insulin. Sliding scale, fixed rate. Sorry? Ketones are 6. Ketoacidosis.
Glucose and insulin.
Good. Any questions? Thank you. Any questions from Glenn for you? Or at home?
No questions from them.
Thank you.